Well, I'm going to go ahead and get started because I know it's 12 o'clock. It is really my pleasure today to have another, another opportunity to look at what our Office of Excellence in Diversity and Inclusion is doing through the academic learning environment. We have not only highlighted one of our students on Chicago Medical School website, which I hope you'll see, but also some rising young stars that we have at Chicago Medical School. And I think it's really great to see what they're doing. There are a lot of them are working in the community and they're just doing great things. So please do that. And we're also lucky enough also, if you guys haven't seen it, the Office of Institutional Advancement has also done a series that also highlights many of the physicians who have graduated at Chicago Medical School, and also like a 200-year fan of some of the individuals in the healthcare services that have really contributed to Black History Month. So having said that, today we are so lucky to have one of our own alum, Dr. Stephanie Whyte. Many of you might know her already because she's been our CMS Distinguished Alumni Awardee in 2013. She's a certified in pediatrics, and she was appointed as the first ever Chief Health Officer of the Chicago Public Schools in 2012. And I think around that time is when you had actually come to Chicago Med and also talked to our alum and talked to our students about the work that you were doing. She's currently serving as Senior Director, Clinical Solutions and Medical Director for Aetna, and is a founding member of CHIE, a private network built to drive more women into positions of power and keep them there. One of the things, she's going to be talking today about COVID-19, the Great Disruptor. It's hard to believe that it's already been about a year since one of our first people actually came to the United States. And here we are still in this interesting life experience. But I'm not going to take up any more time. I want to welcome Dr. Stephanie Whyte back to her alumni Chicago Medical School to talk to you today about COVID. Welcome, Dr. Whyte.
Well, thank you, Dr. Olivier, for the introduction, and to the Office of Excellence in Diversity and Inclusion, Academic Learning Environments, for the invitation. As previously stated, all that great stuff she said about me. I love when people read your bio, you're like, who is that person? It always sounds so great, right? So, but yeah, it's been almost 25, well, it's been 25 years since I was a student there. That has me feeling just a smidge seasoned, we'll call it. No longer spring chicken. I'm gonna call myself late summer, early fall. But wow, 25 years. I'm pleased to return, albeit virtually, and to deliver my thoughts on the topic of COVID-19, the Great Disruptor. I recently had the privilege of being I apologize. I recently had the privilege of delivering the Founders Day address at my undergrad institution. And the theme for the year was health, healing, and humanity. And that kind of set the reflection for my talk, right? And so as I look back over 2020 and thought about that topic, one of the things that resonated with me was something that my grandmother used to say all the time. God bless her. She used to say, if I said it once, I've said it 1,000 times. And for me, for 2020, I said COVID, the Great Disruptor, ad nauseum, because we were forced to constantly pivot and change and think outside the box and do something different and react every day, multiple times a day. And all I could say was like, COVID, the Great Disruptor. That just became the norm. And so as I thought about that, there's not one of us who didn't have our lives impacted in some way, shape, or form by COVID, by this pandemic. And if we think about that, I think it sets the benchmark for which will begin our conversation, right? So my talk today is not going to be heavy laden with the literature. I'm not going to talk to you about the latest COVID vaccine research or anything like that. It's really going to be more reflective about the repercussions that the pandemic has had. And it'll include thinking about what some of the opportunities for innovation and what our opportunities may be as we think about how the disruption in scale has been. And I think it'll highlight for each of us actually, and as individuals as well as systems, what a call to action might be. And what I hope to leave you with is some encouragement and motivation to act. So if I do this thing appropriately, that's what we'll walk away with. So that being said, yet again, COVID 2020 was quite a year. With the onset of the pandemic, social distancing, wearing masks, hoarding of resources, sheltering in place, schools transitioning to remote learning, some sort of hybrid model, businesses going to work at home, some businesses closing temporarily, some businesses closing down permanently altogether. All of our lives being impacted: home, school, work, the extracurriculars, sports, how we worship, our social interactions with friends, with family, how we frequent our local establishments, travel, even grocery shopping. Everything impacted and changed, dare I say forever, but definitely impacted and changed. And conversely, our virtual footprint changed. Our virtual presence has grown, and the appreciation for time and efficiency has improved as well. We've had a return to basics in our family time, in our home environments, in home improvement, living in our spaces. How many home improvement projects did you do last year, right? The innovation has flourished around that. There are many meetings that we previously felt had to be in person. We had to be across the table looking at each other, or it could not occur, that have transitioned to a virtual format that have been both more effective and more engaging for those members. And socially, we've engaged more virtually. I don't know about you, but I've done more virtual paintships, happy hours, family game nights, organizational fundraisers, social events, and holiday celebrations. And I'm not even going to touch on, or I should say, it goes without saying, telehealth, right? So we have broadened our virtual footprint in a manner that you could not have anticipated a year ago, just based off the disruption of the pandemic. But with any disruption comes the need for accountability and action. And I think of any change or disruption as a stirring of the pot or the shaking out of the rug. You know, those things that appear to be settled and just laying there, neat and tidy, are no longer. They're thrown up in the air, and that's not necessarily a bad thing. It opens the door for ongoing change, for evolution, for growth, for improvement. Pick your descriptor, but it presents an opportunity and one we can seize and capitalize on to do better. So health disparities was an area that was not untouched by COVID-19. As Dr. Olivier said, it was just this year, just around this time, it was February of last year, where we really started to think, wow, this COVID thing is here. I wonder what it's going to look like. I'll tell you a personal story. My aunt was coming up to visit me. I'm first generation, and my aunt in Jamaica was going to come and visit. I'm a caregiver. My mother lives with me. Was going to come and visit my aunt. My aunt was going to come and visit my mom. And she's like, hey, I'm coming up, but they just said something about COVID, so I don't know if I should come. And I was like, oh, yeah, I think it's a little bit of hype right now. Let's give it a couple of weeks and see what happens. Yeah. Still waiting. So who could have imagined at that time we'd be where we sit right now, right? So April of, well, before I get there, so these disparities, healthcare disparities, are impacted by influences that impact both the individual and the population's health. And these are known as determinants of health, social determinants of health, right? And for all individuals, all Americans, these influences or these determinants include the availability of or access to healthy and nutritious food, high quality education, reliable public safe transportation, clean air, clean drink, unpolluted air, clean drinking water, health insurance, culturally sensitive healthcare providers. And if you don't have these things, these are the things that can impact someone's health or other than their organic illnesses. I know I'm preaching to the choir, but again, social determinants of health, right? So JAMA, the Journal of the American Medical Association, by April of 2020, started to report on how health disparities were being seen as it pertained to COVID. So there was a 3-fold higher infection rate in predominantly Black counties and a 6-fold higher death rate in predominantly Black counties than predominantly white counties. If you were Black and poor, you were more likely to be hospitalized. And if you were poor, more likely to go to the intensive care unit. Now, this is on top of other disparities that we've already known about, right? So, and according to the 2012 National Healthcare Disparities Report put out by the DHSS Agency for Healthcare Research, Blacks received lower quality healthcare than whites on 43% of 191 measures. And on only 18% of those measures did they receive better care. Our US population is 13% African American, but less than 6% of our US physicians are African American. There has been a decline among Black males applying to and attending medical school in the last 40 years. And although more African American students attend medical school today than 30 years ago, the increase is due to greater numbers of Black women training to be physicians. The proportion of men among African American medical students has decreased by more than 20% over the same 30-year time period. And data from the Association of the American Medical Colleges shows that in 2015, 41% of Black male applicants were accepted into medical school, and that is the lowest rate across all genders and ethnicities. Switching gears, African American women are 3 to 4 times more likely to die from pregnancy-related complications than white women. African American women are 3 to 4 times more likely to suffer a disability from childbirth than white women. And health-related conditions or health conditions that disproportionately impact Black women, such as uterine fibroids, 25% of females 18 to 30 years of age have them, and by age 35, up to 60%, receive very little government research and funding. And African American women are underrepresented in clinical trials. Actually, Blacks are underrepresented in clinical trials altogether. So I start with these stats only to level set for my point of reflection. There was a great deal of reflection and discussion last year, especially as it pertained to the George Floyd tragedy and the Breonna Taylor case and numerous others. But conversations about racism, being anti-racist, implicit bias, and the systemic nature of it all, I believe the disruption of the pandemic set the stage for a certain level of intolerance, as noted by the protests. But also in many instances, it opened the door to probably the most frank and open dialogue that I've seen in my lifetime that included an inclusive and diverse set of conversants with willing listeners and learners. Sorry. So that being the platform and that being, so I'm setting the stage for some numbers and context around disruption. I wanted to give you 3 personal examples, kind of highlighting the ongoing opportunities ahead of us to address disparities and racism on multiple fronts. So I went to a liberal arts institution in Central Illinois, and my undergraduate advisor was the chairman of the biology department. I was a biology major. He was also the chairman of the pre-medical advisory committee. And for the 4 years that I had him, common themes that I heard at the time were I was from the inner city, and that's why my grades was not as good as the other students. That I would never get into medical school with my grades. That I should change my major to French because I was getting A's in French, and I didn't have to major in bio to be a doctor or go to med school. And that unless I got the national average on the MCAT, I'd never get into medical school. And then when I got the national average, it was like, well, you're still never going to get into medical school with those grades. So fast forward, it's my last year medical school, my last year undergrad, and I have been accepted into a pre-matriculation program through CHAMPS to go to CMS. And I'm telling my advisor this, and I'm like really excited. And he said, well, did you get it in writing? I was like, no, I didn't get it in writing, but they told me I'm accepted and I'm going to start. He's like, well, do you need me to send a letter? Do you need me to send a letter? And I was like, oh, that'd be great. That'd be a great little, cherry on top because you already got the acceptance. So he sent the letter and he came to me easily 3, 4, 5 times. I was in micro lab trying to, finish up the end of the semester. Steph, did you get in? Did you get in? I sent the letter. Have you heard from him? And I kept saying, no, I haven't heard from him. But, remember, I already got in. This is just extra. Well, did you get it in writing? I'm older now. I appreciate the nuance of the, did you get it in writing? I sent the letter. Did you get it? Have you heard from him? Okay. School year ends. I graduate. It's the summer. I am now sitting in the dean's office with the head of the pre-matriculation program, 6 other students, and we're sitting there having a tat-a-tat with Dean Hansen. And the head of the pre-matriculation program looks at me and says, I got your letter of recommendation. And I say, so I'm saying, okay, great. Because, the doc was like, yeah, he's going to get it in. And then he told me what it said in front of Dean Hansen and these 6 other people that I don't know. And it said, I do not recommend Stephanie Whyte for this program. She will never withstand the rigors of a medical education. Now, many of you are just now meeting me. I'm a little expressive. And so at 21, I didn't have all my expressions in check. So I can only imagine what my face looked like in that moment. And what I was thinking about then was, oh my gosh, I'm here with the dean and these people I don't know. And I was just trying not to cry, right? Keeping it real. And how could he do that to me? He kept coming to me, Steph, did you get in, right? I'm just I'm thinking my chances now for medical school are just torched. So I'm here now. So clearly there's a happy ending, right? We got a happy ending. So it turns out we started summer anatomy. I was able to apply for advanced standing. I go through, I graduate. I send a graduation announcement because that's how my petty is lined up. I send the graduation announcement with my picture and the message, guess who withstood the rigors of a medical education, to him. And then at the point when I actually accepted the Distinguished Alumnus Award, Dr. Hansen was the one who actually gave me presented me with the award. And he talked about that day and hearing that and how it incised him. And so, it's a biblical saying, what others have for your mean for evil, God has for your good. And that was just that moment. He was like, that moment just sealed it. Absolutely. I was in the program we were moving through. But again, let's just talk about somebody in a position that is designed to move people forward. Someone who saw my struggles, saw my resistance. Yeah, there were some inconsistencies, but saw that I could put something forward. I had an opportunity to give me a chance and try to leverage their power against me intentionally, as opposed to use it to assist me on. I ask you to think about what the driver of that was. Example number 2. I'm a resident. I did my residency in New Orleans, and I'm also a chronic migraine sufferer. And I was on day 2 of a migraine, and one of my fellow colleagues, my intern year, said, I'm going to come and get you and take you to the emergency room. So now I'm a resident. I don't want to deal with medical students. I don't want to deal with residents. I just want to see the attending. So I did not go to any place in the LSU system. I went to this other hospital where I'm just going to see the attending, be in and out, and not have to deal with all that hoopla. Poor decision. If you want better care, go where there's trainings people. They're smart. I'm just going to say that. But I'm there And I'm in a quiet room and it's nice and dark. And then here comes the doc. He flips on the bright light over my head. He walks up to me and he goes, "What's your problem?" And I explained to him, I suffer from migraines. I've seen at the Diamond Headache Clinic in Chicago. I've taken all of my medicines. I've maxed them out. I think I'm in rebound. The headache is not going away. I'm still at an 8 to 9 out of 10. It's been, X amount of hours. And he said to me, "I don't give narcotics for migraines. I don't care what you give, dude. I got a headache. I just want it to go away." He said, "I don't give narcotics for migraines," about 3 or 4 times to me during this setting. He showed no compassion. He, at some point, I think myself or my friend said, "Dude, scrubs, we're residents, like we're doctors, like, hello." Like I don't think I've ever felt so, I don't even know what the right word for it is, but it was very dehumanizing. It was I've never treated a patient like that. Even my most difficult patient, I have always been respectful to, and it was very disrespectful and subhuman. I've never forgotten that. So eventually I get treated. The headache leaves. He even came back in there with the big PDR, big medical journal to point to me to kind of show me what I could and could not take. I can't see that, dude. My head's hurting. It was a horrible encounter. And I told my chief resident about it the next day, who was also another white male. And he, he had some really choice, explicit words and told me I need to write the medical staff, and let them know what happened and my whole encounter. And I struggled with that because for me, I was treated, I had the appropriate outcome. How do you put the soft things in writing? How do I say, "I'm writing to tell you Dr. So-and-so was mean to me. I'm writing to tell you he was mean to me, and I think he was mean to me because I was Black"? How do you say that when all he really said was, "I don't give narcotics for migraine"? How do you contextualize that? So it was, yeah, but it's 25 years later and it still brings out something in me. So that it's more to that. And then I will give you the last one. The last one happened recently, just this December over the holiday. And it was to someone who's in my social network, not that someone I knew personally, but someone who's in my social network. And I kind of saw it unfold. And this is a physician who's in the Chicago area who actually contracted COVID and went to a hospital in Indiana and was not receiving what she felt to be optimal care, was not being treated as a member of her own care team, was not being heard. She leveraged the administration and the medical team at the hospital and was just not being treated favorably. So she took to social media to say, "Oh my gosh, this is how people die. I can't believe this. I'm concerned." And she was like, "If I am an educated medical professional here advocating for myself, and this is the treatment that I'm receiving, what happens to the average Joe off the street who comes in looking for care and compassion and quality care?" So she ended up after a few days, she ended up being discharged from that facility. Within 12 hours, she was readmitted at another facility with 103 fever and a pneumonia. Her situation decompensated. She ended up in the ICU, intubated, and she expired. So, COVID, the Great Disruptor, doesn't discriminate. So it doesn't matter whether you have a medical degree or not. If you are if you're right with the right comorbids and you get the right infection, you will be impacted. And it's just horrible as a medical professional to see this happen to a colleague, to hear that colleagues, this is how we treat each other, let alone how do we treat someone not in the same space. And to have the CEO of the facility come on after that and say that, "Oh, the staff found her to be a bully." Is that the good optic? Is that the message that we want to put out there, really? So when we talk about, I use those to throw back to some of the examples, right? We talk about social determinants of health. Well, let's talk about culturally sensitive healthcare providers. I didn't experience that as a resident. She clearly did not experience that in her experience, right? When we talk about the need to have culturally sensitive medical providers, we talk about the fact that our medical landscape doesn't even match our demographic of a society. We talk about the fact that we're seeing trends that haven't changed since 1977 or 78 for our African American men in medical school. We celebrated in February National Women's Physicians Month as well as National Black Women's Physician Month. Less than 2% of physicians are African American female. A third of physicians are females, but less than 2% are African American females. I mean, so there's work to be done. And as we talk about solutions, because I'm going to transition there, as we talk about solutions, there's definitely a strong argument for creating a diverse medical workforce on multiple levels and tangents that allow us to address what are a great deal of healthcare disparities. So, and I think, again, if we go back to the concept of COVID as the Great Disruptor, I think when we get into a period of disruption, I think we can think outside of what is the traditional box. I think it calls to light an opportunity to motivate us to create a culture where conversation is happening, where people are listening, where we can move levers. And so I encourage us to think about how it impacts us individually and where our opportunity is to move forward. So as individuals, I think we take stock of whether we're being anti-racist. Do that reflection. What does that even mean? We can become an ally. We can look to what that looks like. So the University of California, San Diego, on their website, has a wonderful anti-racism guide and wonderful resources just about anti-racism and allyhood. So I would encourage everyone to just take a look at that, whether it's books to read, whether it's a guide on what allyhood is, whether it's just understanding what the concept is. I think as individuals, we all need to understand where we sit and what the climate is changing and the opportunity to act. Anti-racism and implicit bias training should be mandatory for healthcare professionals. I think in some areas we do some training around cultural sensitivity. I'm not certain how mandated it is or how widespread it is, but I know to renew my license last year in Illinois, I had to train on opiates because that's the issue. It'd be great if we had to do some training on cultural sensitivity, on implicit bias, or on anti-racism. We deal with a diverse society. We need to be able to address each other as individuals and remove some of our own preconceived issues to deliver care. We need to create, again, a diverse medical workforce. I think it's crucial to quality healthcare, and the impacts are far-reaching. It'll definitely help our ability to assist our underserved populations with access to healthcare. It'll expand the number of stakeholders that are embedded in establishing quality of care policy and contributing to healthcare disparities work, right? Our minority medical students are more likely to work in underserved medical communities, and that also influences the community's access to healthcare. Diversity provides a bridge for those working in healthcare policy and community leaders to collaborate and specifically discuss those areas that directly and indirectly impact public health interests. And, there's great opportunity for innovation, and through the lens of different perspectives, it's needed on the health equity research front. So we need to leverage every aspect of every individual we have for what they bring to the table. It can't be monolithic at all. And so the more we engage on multiple fronts, the more we're able to have a broader impact. And then research shows that racial and ethnic diversity in medical education improves learning and cross-cultural competencies of all doctors. And I know, I trained in New Orleans, and in addition to having a baby face, and so people challenging me on my age as a young resident, as to, are you really the doctor? It was interesting to be in a place where people couldn't fathom that I could be the doctor. So it was one thing to look young, but it was another thing to actually be a young Black doctor, because that was inconceivable. And so I was challenged on numerous fronts when I walked in the room, because I couldn't possibly be the doctor. And I was told often that I didn't look like a doctor. And because I'm from the South Side of Chicago, I asked them, what did a doctor look like? And I would sometimes challenge, is that because I'm not an old white man? And so it was always interesting to see what that response would be. But there are preconceived notions limited by what people actually see. And if you don't see it, you can't believe in it, and you don't aspire to do it. It doesn't become what is your norm. And so if we don't have systems in place to support, diversity, if we don't have systems in place to support ensuring that our African-American males are in medical school and successfully matriculate through and move forward and are there so that our young students and our young kids can see them and know that it exists, then they won't believe it. My essay for residency talked about my pediatrician. And my pediatrician was on the South Side of Chicago, and he was not an African-American man. He was a Jewish pediatrician who let myself and my Jamaican mom mispronounce his name the entire time we went there. And I learned that we were mispronouncing his name because he had a daughter who subsequently became a pediatrician, was at Northwestern. And I realized that, and I was like, how come she pronounces her name differently than his? And then I realized, we pronounced his name wrong, and he never corrected us. But Dr. Pockman, which is what his name actually was, and we called him Patchman the entire time, and he never corrected us. When I went to see him, he told me, now in addition to giving me the red balloons every visit, which was awesome until, of course, we had to ban balloons. But every time I went to see him and I told him I wanted to be a pediatrician, he asked me what my grades were. He took me in his office and he showed me all his degrees and told me to go to Duke University. When he did my finger stick and did a smear and looked at it under the microscope, he had me look under the microscope and he pointed out all the different red blood cells that there were. He pointed out the white blood cells, the entire 9. He would show me journal articles and show me where he had been published and show me his name every single time I came to his office. I am the first generation little Black girl of a single parent mom who said I wanted to be a doctor. He did not have to spend time on me, but he did. When I got accepted to residency, he was still working half a day a week in that office with his nurse, who still wore a little cap on top of her head. And I showed up there one afternoon with my I'm going to give him this essay and tell him, what he said to me and read it to him. And he looked at the nurse, he said, I don't remember her. You remember her? She's like, I don't remember her either. So, in addition to my feelings just being a smidge hurt, I realized that you don't know what impact you have on anyone in the moment that you have with them. So what I internalized from that was every opportunity I had in front of every child, I was going to bless them with some sort of Dr. Whyte wisdom, because I didn't know what they were going to take from me, what was going to resonate with them, but they might hear from me something that no one else was telling them. And I've always done that with every patient I ever saw. And so if it was the play it forward, that's what it was. So I will always think wonderfully of Dr. Pockman and what he did for me. And where I saw that play back for me is when I was still in clinical. One of the patients I had taken care of came to me, and he was a quiet little boy, and he was, I used to love to play with my kids' names, and his name was Pedro. I would say Pedrito every time he came, and we'd have a wonderful time. And he was about to graduate from high school, and I was like, so what are you thinking about? And he's like, I've been coming to see you all this time, and I really think I want to be a doctor now. And he could have floored me. He could have floored me. He was one of these kids who was very quiet. So I always like to pick with the kids who are quiet and kind of bring them out of their shell. And as he got older and he started engaging, he just engaged me in this conversation that I did not see coming. If you would have asked me who, I would never have picked him. But it just, again, punctuation. You don't know the impact you have when you engage with people. So all of that to talk about social determinants of health, culturally sensitive, being able to see it, and being able to render it back to community and have that make a difference and an impact, and the need for diversity. So I know, again, that I'm preaching to the choir, but I would be remiss if I didn't wrap up by saying we're still in the pandemic. So that means we need to continue to do our part, wear our masks, wash our hands, socially distance. And when the COVID vaccine is available to us, if we have not already taken it as healthcare providers, make certain that we take it. But we also have an additional responsibility to educate and promote it amongst our friends, neighbors, and relatives, as there is vaccine hesitancy out there. And we need, this has forever changed our life and the footprint of the world as we move forward. So I think that it's important that we do our part in spreading as much awareness and education as possible. So thank you again for the opportunity to come before you today to just kind of wax eloquent on COVID, the Great Disruptor.
Wow. Thank you, Stephanie. That was amazing. I mean, lots of reflection of the things you said, your life experiences woven into that, and why it's so important. And, I'm in awe of the things that you've done. And you've made a lot of comments. I'm going to ask the audience if they want to ask some questions to please either raise your hand or you're able to unmute yourself to do that. One of the last things that you said was sort of about perhaps our responsibility as healthcare providers for our community. There are lots of people, particularly sometimes Black and brown individuals, who have a mistrust for the system and are sort of afraid of or don't want to take the vaccine. What do you think we could say to those people? And of course, you're in that role now of being Aetna and insurance. What do you think? How do you think we can make people, or at least educate them better as to why it may be important to take the vaccine?
So I think we need as many advocates as possible speaking about it. And I think it always is better if it comes from someone who's relatable to you and your experience. Full disclosure and transparency, I'm pretty authentic. I had vaccine hesitancy. I had said that I ain't taking that shot. Catch me on year 5. I am not going to be the first one in line, trust. And I actually attended one of these Institute of Medicine Chicago events, and Dick Durbin was there, but he had ceded his time to the guy from the NIH. And it was so informative to me. And so whatever my issues were, and I'll be honest, last year, everything with COVID was so politicized with the administration that we had. It was difficult to tease out fact from fiction when we weren't leveraging science anymore. And I think for me, that's where a lot of my mistrust was seated. So once I actually heard science, I was like, oh, duh. And my perspective just completely changed. So my view completely changed. I'm still waiting for my injection. I moved from the I'm not going to take it to the I'm not going to be first in line, because my colleagues who are actually treating people every day need to get it before I get it. But I'm right after them. So whenever it's available for me, because it's a shortage, whatever is available for me, I'm next.
Great.
But yeah, I'm sorry, to concisely I answer that. The message needs to be brought by people you trust, people with the facts, and that's who needs to be delivering the message.
Great. we know that in medicine there certainly are implicit biases, and what do you think? Training. Somebody was asking, what does successful implicit bias training look like? Do you do that at Aetna in your company?
So we train on, we definitely have mandatory training on cultural sensitivity. Um, there are trainings out there, and I know there are organizations putting trainings together. That is not my area of specialties, so I cannot speak to it specifically. I think that the acknowledgement that it exists, because I know that there is still some argument systemically about whether it exists and whether it's needed, is out there. So I think accepting the fact that it does exist, this is a systemic issue, is one half of the battle. And then leveraging some of the resources that are available becomes the next piece. So I'm certain there's some evidence-based stuff out there for you to leverage. But It's not a one, I think the other piece too is it's not a one-shot deal. We don't do it once, check the box and say it's done. It has to be consistently done. So whether that's annually as a part of, your annual training or your annual renewal, whatever, it needs to be constantly done. It needs to be embedded. These can't be checkbox activities. It has to be a commitment to the process and ongoing work to make it a part of the fiber of the institution.
Yes. Are there any questions from the audience? Let's see. Lucy says, just being able to say to patients that you had some hesitancy about the vaccine, probably with the camera that came around, you have probably more information to them, and it's more powerful. And she was sort of saying the same thing that you did. The experience resonates with them because a lot of people are out there, and you could say, hey, I didn't think that was the case, but here we are.
Oh, absolutely.
You talked about,
I was just gonna say, it's really important to be authentic. And I think when people can appreciate your authenticity and that you're coming to them with this is, the truth. I'm not trying to put anything over on you. This is what we know. I think that's where a lot of the hesitancy lies, right? That we aren't always forthcoming. It's do as I say. We aren't having a real conversation about things. And so
you talked about a couple of things that we have actually tried to make changes at Chicago Medical School. And one of that is in medical education and how we actually train our students to be more aware, culturally competent, and also sort of those one-liners we always sort of, were doing when we were Black, female, husband, obese and stuff like that. So, and you talked about some of the things. What are things that you think we can teach our students to be not like that doctor that you had, but, what it is that you think we could do in medical education, and then the importance of mentorship in those processes.
Oh, wow. So mentorship is huge, right? So that was something I never had. And I think it can make a huge difference. So cultural sensitivity goes a long way. I don't remember which doc this was that told me this, but it resonated with me. It was something I always told my interns and my students as they came along. And it's my pet peeve as a patient. And as when I hear other people do this now, is that you don't know the patient and you're coming to them just by default in a position of authority and power. Do not strip them of their respect and their power by coming to them on their first name. So don't walk into the room and say, hi, Mildred, I'm Dr. So-and-so. You say, hi, Mrs. Olivier. Or if the chart says Dr. Olivier, say, hi, doctor. You give them that respect. Allow them to say, call me, but don't first name them. So it is, when I go to the doctor's office and someone says, Stephanie, my skin boils every time. but I have other issues too. And it's the same. So I think that when you walk into a room, you pay them, that changes the dynamic of the relationship in such a tremendous manner, Well, I practiced for over a decade in the city in a mobile clinic where I was in some of the roughest neighborhoods of Chicago. Families came on, and these families have had to fight for everything. And my driver used to say, why is everybody so angry when they come on here? And I had to explain to them, I said, they fight for everything every day. No one gives them anything. No one is nice. They come armed and ready to have to fight all the time. So if you say, pay attention, watch their mood from the beginning to the end of the visit. So, and you can see the guard fall down, you know, because they come on like, and as they continue to talk, they realize, I don't have to fight. Oh, okay. And you can watch that. But when your struggle is such that everything you get, you have to fight for, where you're on beg, borrow, steal, lie, whatever, because that becomes your daily reality, that's how you approach everything. And there's no trust there. So when you come on and you're used to people calling you such and such, and I say, hi, Mrs. So-and-so, how are you today? I'm fine. Okay. And I would just ignore it and continue to act like you weren't being rude. And someplace by 10 minutes in, the mood completely changes, and they're engaged because they realize, wait a minute, I'm being treated and respected as a human. And the dynamic and the rapport that you build in that relationship is phenomenal. Now, I know that there are challenges with healthcare where you got 8 minutes to see somebody or less, and you don't necessarily get to engage like that, but that is the difference. And something as simple as always coming in and identify yourself by saying, hello, Mr. or Mrs., and I am, makes a huge difference in how they remember you and how they'll engage with you.
Thank you. Well, as you know, our dean is a pediatric infectious disease specialist as well, Dr. Archie Chatterjee, and I'm going to also give her the floor now as well. Dr. Chatterjee.
Thank you very much, Dr. Olivier, although I do have her permission to call her Mildred. But Dr. Whyte, thank you very much for your wonderful, wonderful presentation. Sharing your personal stories, you know, you've seen some of the comments in the chat, I'm sure. I think as human beings, these stories mean a lot to us. And you've illustrated your points by sharing very personal stories and some of the really egregious obstacles that you faced with, I imagine, great grace and true resilience to get where you are today. So you are a role model and someone of whom we are extremely proud as a CMS alum. So thank you again for your willingness to share those stories with us. One of the things, you know, when you were talking about the vaccines, and as you know, and most of the people in the audience today know, I'm a member of the advisory committee to the FDA. This used to be a sleepy old committee that nobody really bothered about until COVID came along. And suddenly, you know, we find ourselves thrown into the spotlight. But when you emphasized the importance of the science, the research, and not paying attention to the misinformation and disinformation that's out there, I was talking to a senior member of our leadership this morning, and you know, people come to me to ask these questions. Doesn't matter how much knowledge and expertise they have, but the question was around, you know, is there benefit of one vaccine over another? And I always point to the research to say, we have no comparative trials. So whatever you're hearing about is anecdotal, and you have to put that in perspective when we're teaching our students evidence-based medicine, that you cannot rely on that. So I say that because I've been thinking about COVID and the vaccines and prevention measures for a whole year, right? I think about it in a different way. I know that 8 billion other people have also been thinking about it, but I think about it in a different way than perhaps many other people do. And I have to say that I am continually being educated. So over the weekend, I was watching a TV program, And the speaker is from the University of Virginia, brought up this point about access to vaccines. You talked about hesitancy, and yes, hesitancy is definitely something that we have to deal with among healthcare professionals, among people who are from minoritized populations. You know, we get this question all the time. Were people who were Black and brown included in the vaccine trials? And so, you know, those are important questions to ask. But what this individual was focusing on was access. And, you know, I have thought all along that the plan put forward was a reasonable one, which is, you know, we vaccinate our healthcare professionals and our frontline essential workers at the beginning, and then we go to the next level, et cetera. And she pointed out a few things. She said, if you think about, okay, so you're going to offer vaccines to healthcare professionals, right? As you mentioned the data, the proportion of people who are from minoritized populations who are healthcare professionals is very small. Mm-hmm. And yet we know the huge disparity in the way that this epidemic, this pandemic has impacted that population, okay? So where's the equity there? There's no equity there, okay? If you look at people who are over a certain age, we know that there's a difference in life expectancy of people who are Black compared to the majority population. And yet we are saying, well, we want to vaccinate people who are a certain age and higher. Well, the vast majority of people who are going to be impacted by this pandemic will perhaps not reach that age. So there are disparities that are perpetuated without people necessarily wanting to do that and not thinking this through sufficiently. And I have to say that I'm one of those people, because I didn't think with that lens on, and I've had to do that to say, yeah, there's disparity here, and what can we do to change that? So thank you very much again for bringing your thoughts to our group today. A lot of learning for us all to have from that. I will say one more thing, and that's with regard to your point about a trusted messenger. And I'm very happy to be part of this group. Next Wednesday, I will be participating in a panel discussion that includes not just me, but Dr. Allison Arwady, who is the Commissioner of Health for Chicago, Dr. Lisa Green, who is an African-American physician. Mm-hmm. And what we're trying to do is reach the Black population to have them hopefully have people who are trusted speak to them about the importance of vaccination.
Right.
So with that, I will bring my remarks to a close, and we look forward to your engaging and participating with us as we all move forward beyond this pandemic of COVID, but we will continue to have to address the other pandemic, which is of racism. Thank you very much.
Absolutely. Thank you. It's my pleasure.